Assalamu alaikum. Just allow me to share my screen. Because I think it was allowed, but I couldn't share my screen now. I think Batul has disabled the feature for all. So if Batul can allow me once again to share my screen, I would be grateful. Okay. I can't share my screen.
Oh,
Sorry. Share screen. Need to share. Mhm. Do you see my screen? Do you see my screen? Because here host disabled attendee, but I cannot. I am the host, but I cannot even unlock it for myself. So I don't know how to minimize view. So Batul, can you make yourself the host and allow me to share my screen? So we reverse it, maybe it might work. So Batul, make yourself the host and unlock my
Doctor,
share.
I can't make myself the host. You make me the host.
How could I go? How I am not, in
Press my
technology.
name. Yeah, you can press my name.
Okay, press your name, and I would say
Make host.
make. Let's just okay. Back, reload, save, open, send to your. Sorry, Batul. Where is Batul? I cannot find you now. I cannot find you now. Okay. I don't find you. Batul, okay. You are the host, Batul. Batul, you are the host.
Yes, doctor. Now I will search how to make you share your screen.
Okay, طيب. Okay. It was at the beginning, it was easy, but then
Doctor, I think you can't. You only can open video or share your screen, one of them. So I can share your screen for you.
okay.
Send me the slide.
Video, share screen. Still, it is not available. I I I I stopped sharing video, but it didn't work. Now it comes. Okay. Window. Okay, it comes now. Okay, share. And I think now you can see my screen. Correct?
Yes, it's clear, doctor.
It's clear.
طيب، يلا بسم الله الرحمن الرحيم وبه نستعين وعليه توكلنا وهو رب العرش العظيم والحمد لله رب العالمين حمدا كثيرا طيبا مباركا فيه كما يحب ربنا ويرضى. I am greeting you from المليدة. أنا حسبتها تنطقوها المليدة، هي المليدة صح؟ أنتم معاي؟
ايه
صحيح.
معك دكتور.
اسمها المليدة ولا المليدة؟
المليدة او المليدة.
المليدة. أبد أبد أبد، والله يرفع قدركم في عنيزة.
قدرك يا دكتور.
القرعاوي والمطيري والنبهاني، وما شاء الله في أسماء طيبة وجميلة. في دكتور معانا زميلنا دكتور عظيم اسمه الدكتور فواز بن قبل المطيري، من الحريص من عنيزة. نعم الرجل استشاري قسطرة. طيب بسم الله الرحمن الرحيم. We start with the first case. So are you seeing the screen in front of you?
Yes.
So comment on the screen. So this is, I give you a short history. This is a 37 years. So these are ECG and cardiology scenarios, which I have seen in the last 3 years. So this is a lady, is 37 years old, and she came to the ER with severe shortness of breath, and they did the ECG. Any comment? Anyone can volunteer. You want me to pick randomly, or you can? Or you can write on the chat box. So write on the chat box. So tachycardia. So Batul has mentioned tachycardia. So then we need, whenever, okay, RH has mentioned regular tachycardia with no P wave. So it is regular. It is regular, narrow, complex tachycardia, but they are B waves. They are B waves. If you look to the screen, so they are B waves. The T waves are evident, but they are B waves besides the T wave. So this is sinus tachycardia. So, but whenever you have tachycardia, you need to make sure about whether it is regular or not. And the second feature, you need to see the QRS. Is the QRS narrow or widened? And the third feature, as you have already encountered, whether they are clear B waves or no B waves. Because if they are B waves, it could be sinus tachycardia. So this is a patient who came to the ER with severe shortness of breath and sinus tachycardia. Let us now give me differential diagnosis of such tachycardia. What could be the differential diagnosis? So it could be atrial fibrillation. Okay, I accept that. What else? Atrial flutter with 2 to 1 block. So if you want to mention flutter, it is 2 to 1 block because the rate is like 150. So it is like atrial flutter with 2 to 1 block. Atrial flutter with 2 to 1 block would appear very regular, not like atrial fibrillation. Atrial fibrillation would be usually irregular, and you will not see B waves. But atrial flutter sometimes with 2 to 1 block can come with such. So a 37 years old with with sinus tachycardia, caffeine. So caffeine misuse. Caffeine misuse, correct. Energy drink, if somebody has more than 2 cans per day. So energy drink can also cause sinus tachycardia. But important for a lady, always think about pulmonary embolism, because the commonest ECG manifestation of pulmonary embolism is sinus tachycardia. So sinus pulmonary embolism, sepsis, dehydration can also, and also anxiety attack or phobia. So all these can also cause sinus tachycardia. What would you like to see in a patient with abnormal ECG and shortness of breath in the ER? What would you like to see the next step, laboratory-wise? You can write to me in the chat GPT box, cardiac enzyme. So this is the cardiac enzymes. I'm not sure whether you can see the abnormalities. The abnormalities are either in yellow or red. So the white figures are considered normal. So this case happened last year. So what would you tell me from the look on the laboratory markers? So please write in the chat GPT, what did you see? So elevated troponin I. So elevated troponin I. Elevated troponin I indicate MI as per universal definition of MI since year 2000. Any troponin elevation with any kind of symptoms or abnormal ECG is considered MI. What else could be? Also hyperthyroidism. Okay, excellent. So very high T4 is high and T3 is high and TSH is very, very low. So what could be the diagnosis? Is this lady who comes with severe respiratory distress. And TSH was repeated more than once. So what could be thyrotoxicosis storm? Excellent. So it could be hyperthyroidism, but it is likely a storm because the patient comes with thyrotoxic storm and severe shortness of breath. This patient came last year and she was admitted to our medical department, and endocrinology treated her for her Graves' disease. And she was not really before to be sick, but I mean, sometimes you can get a very atypical presentation with positive troponin I. So a patient with pulmonary embolism, a patient with septicemia, a patient with dehydration might come with severe cardiac symptoms, and the troponin I is positive, but not necessarily the primary diagnosis is cardiac. The primary diagnosis was non-cardiac. But we call that type of MI. So what type of MI we call it? What is the type of MI? If it was a thyrotoxic storm, it is called type 2 MI. So we have two types of MI. We have type 1 MI. This is a patient who comes from home with chest pain and the troponin is positive, but he has no other issues. Type 2 MI is usually in ICU, in dialysis ward, or in neurology ICU, a patient with a stroke. So type 2, it means that MI was secondary to the insult, to the other insult. Could be septicemia, dehydration, could be other scenarios that has produced an increased level of troponin. And in such cases, even it indicate poorer prognosis. So a stroke patient with positive troponin I is more sicker than a stroke patient with a normal troponin I. This is an excellent question. There is no clear ST elevation because usually type 2 MI is what is called non-ST elevation MI. You might get a normal ECG, you might get ST depression. So we call that non-STEMI. We call that non-STEMI. So we take you to another example. This is a scenario of a patient. We received a call several years ago about a 30-year-old lady, 2 hours post-laparotomy for a suspected pregnancy. The lady was recently married, and she came to the ER with abdominal pain, and she collapsed in the ER. She was also febrile. So a 30-year-old lady, recently married, and she came to the ER and she collapsed because of fever and abdominal pain. So what do you think is, what is our suspected in a young lady? So a young lady recently married, abdominal pain, shock, collapse. If you have such patient in the ER, what is your number 1 diagnosis? Number 1 diagnosis is ectopic pregnancy rupture or pregnancy complication. Always think like that. Either it is an ectopic pregnancy that has been ruptured or other complication of a normal pregnancy. So what would happen if somebody is in shock status? He will be taken to the laparotomy. Laparotomy means a wide open incision to search for the ruptured ectopic pregnancy. Let us read the laparotomy report. The laparotomy report say no ectopic pregnancy. The uterus is gravid, it means it is pregnant uterus with a 2-month fetus, and the abdominal organs are especially inflamed, including the pancreas. So the patient was intubated, she was very sick, and she was on inotropes, and this is her X-ray. I'm not sure whether you are compatible or are you at easy with reading an X-ray. So this is the patient X-ray is from ICU. So any interpretation of the X-ray, I would like to hear your. So there is cardiomegaly, although it is a portable X-ray. Important to note that there are ECG leads. So it means it is the patient is in a monitored area. As the patient is intubated, and there is an endotracheal tube. There is a central line, and there is a nasogastric tube. Why we put a nasogastric tube for every patient who is intubated? What is the use of the okay, because he might aspirate, but it is important to note if somebody becomes intubated, the stomach dilates too much. So it is important to relieve the gastric or to do gastric decompression, as El has mentioned. So this is a patient who has got intubation. These are the monitored ECG. There is a central line, and there is an endotracheal tube, and there is a nasogastric tube. So what is the ECG telling us? Have a look at the ECG and tell me just one feature from the ECG. Just tell me one ECG feature which is very remarkable. And look to V6. Look to V6, lead V6, and lead 1, and tell me also about the ECG overall. Yes, RH ask, is there a pulmonary edema in the X-ray? Yes, it is congested chest X-ray. Okay, QRS is narrow. Okay. So see the ECG. What catches your eyes on the ECG? Low amplitude. You are right. So it is a low voltage ECG. And they are minimal ST elevation. So this patient has got severely low voltage ECG involving both limb leads and precordial leads. And there is sinus tachycardia. The heart rate is around maybe 100, borderline sinus tachycardia. What else would you like to see? If we did an ECG, it is a little bit abnormal, or there is minimal ST elevation, there is low voltage ECG, there is sinus tachycardia, X-ray is showing pulmonary congestion, the central venous pressure is elevated. What would you to see? You would like to see the vital signs, because this is a patient. So the vital signs reads, her temperature is 40 degrees centigrade. Her systolic blood pressure on inotropes 4 is 90 to 100. Her weight is 70, and her blood sugar is 12. Why patients in ICU, they develop high blood sugar? What is the importance of that? What is your comment on the T wave, troponin I, dehydration, cortisol effect? Excellent. ZU mentioned cortisol effect. So hyperglycemia is frequent in ICU, even no diabetes. So it is important to know that it could be the effect of cortisol. So ZU, or the effect of stress. So this is kind of stress hyperglycemia, and people are actually arguing whether to treat or not to treat this kind of hyperglycemia in ICU. But they put certain level of blood sugar. If the blood glucose doesn't exceed 10 millimoles per liter, you don't need to treat. If the blood glucose is below 10, you need to observe. Some people advocate the use of insulin, but it could be a serious effect, because cortisol will be very high in patients with a shock status. Yes, in some people, there is a very important question. While patients in ICU, not all of them, they elevate their glucose. It means this patient or other patients who have high glucose are already genetically predisposed to diabetes. Maybe they are not diabetic now, but after 10 years or 15 years, they might develop frank diabetes. because of their family history, because of their genes, because of other scenarios. So it is important to note stress hyperglycemia, it can go into up to that degree. And M has calculated the blood glucose level to be 221, correct? So we go back and we needed to see her troponin I. This troponin I was taken as the year 2009. So in today's figure, you need to multiply by 1,000. So the troponin at 2009 were 3,000, 10,000. So the maximum troponin I the patient had was 10,000. So what would you do next after you do an ECG, X-ray, vital signs, laboratory markers? What would you like to do next? Leukocyte count is 18,000, 13,000. Okay. What would you like to do other than already you did? Echo. Okay, that is the echo. By the way, echo, do you see my cursor? I'm not sure whether you see the cursor. Let me see. Okay. Ben. So I am going to tell you about the LV wall thickness. So the LV wall thickness is very thick, and this is pericardial effusion. So the LV thickness is very, where is the eraser? So the LV wall thickness is very edematous. The wall of the heart are quite edematous. So what do you think is the diagnosis? So the diagnosis is a myopericarditis in a pregnant lady who is 2 months pregnant. So are you following? So this was a case of acute fulminant myopericarditis. Why we said myocarditis? Because the muscle of the heart are edematous and inflamed, and the thickness exceed 1 centimeter. And the ECG is showing low voltage, and there is minimal ST elevation. Maybe it is difficult to tell. So it was a fulminant case of acute myopericarditis in a pregnant 2 months lady. So how we treat now acute fulminant myopericarditis? If you have such case today in 2026, how you treat such patients? Non-steroidal anti-inflammatory for simple cases, I agree with you. So you give anti-inflammatory, you can give colchicine, you can give simple painkillers, aspirin. How much aspirin you give in acute pericarditis? And for how long you give aspirin? What is the dose of aspirin if you would like to treat acute pericarditis? So if you want to treat acute pericarditis, you give aspirin 2 to 4 grams because the anti-inflammatory action of aspirin need a very high dose of aspirin. Aspirin as antiplatelets, you need only 81 milligram PO daily. So steroids, when do you use, okay, excellent. When to use steroids in acute pericarditis? This is an excellent suggestion. But not all patients. Autoimmune, excellent. SLE, systemic lupus erythematosus, connective tissue diseases, or when the first line treatment fails. So you don't use steroid in all cases of pericarditis. You use it when it is secondary to SLE, or when you give non-steroidal anti-inflammatory and there are no response, or non-steroidal are contraindicated. That is very good. You are up to the, mashallah, tabarakallah, mashallah. Okay, so what is ECMO? What did we do for her? We did precardiocentesis. The patient moved to the ICU, cardiac ICU. She was still on inotropes. A decision was made to involve cardiac surgery and consider ECMO. So what would you, sorry? So what is ECMO? Okay. So what is ECMO? Anybody can tell me what is ECMO? Excellent. RH, it replaces lung and heart function. So ECMO, you know, I am an old guy. 10 years ago, I remember a tweet from Al Qasim. Somebody from Al Qasim wrote about a young boy who is 15 years old on Twitter, on X. He said a patient died because of myocarditis and there was no ECMO machine. And I still remember that. Now in our hospital, we have ECMO everywhere. In all ICU in the hospital, cardiac ICU, general ICU, everybody has their own ECMO. So ECMO is extracorporeal. I think, remember me to give you a lecture about ECMO is extracorporeal membrane oxygenation. It has two types, VA ECMO in cardiac, and VV ECMO in respiratory failure. It has to be connected to a central line, to a vein, a major vein, and then to an artery. Like you take the blood, the deoxygenated blood from the jugular vein, and you retain the blood through the femoral artery. Outside the body, you try to oxygenate the blood and take carbon dioxide out. So it helps with oxygenation and gas exchange, ECMO. ECMO is now considered a standard in myocarditis or severe respiratory failure. It is a bridge. What do we mean by a bridge? It keeps the patient alive until the patient recovers. So it is called a bridge. Or ECMO is outside the body. ECMO is outside the body, like heart, lung machine. ECMO provides oxygenation only. Heart, lung machine is a mechanical heart. A mechanical heart machine that is used in cardiac OR to push blood to the brain and rest of the body. So heart-lung machine is a very complex machine. المسؤولين عنها who are responsible for the heart-lung machine are the perfusionists, إخصائيين تروية القلب بالدم. أثناء عملية القلب المفتوح القلب يتوقف عمله ويكون القلب موصل الأورطة sending aorta والديسندنج والجي في بي يكونوا موصلات بجهاز لنج صناعي برا يضخ دم للدماغ ويضخ دم لبقية أجزاء الجسم. فالهارت لنج machine is more complex and it is used in during heart lung machine. An ECMO can be used in ICU. You don't need to open the heart. But the heart lung machine, you need to connect to the aorta. It is more aggressive and more invasive. So this is the heart lung machine. So at that time, we considered to attach the patient to ECMO because the patient was on inotropes, she was on everything, but we couldn't. So how you treat myocarditis at that time? At that time, we gave high-dose immunoglobulins because it was an immune reaction. We gave steroids, as you have already mentioned. The patient was intubated. How we do an echo? We do an echo every 6 hours. And we give IV antibiotics. So what do you think the antibiotics you can use if you suspect septicemia and there is... Thank you, Maria, for doing the echo. This is my echo tech. She did an echo. I am on call today, so okay. So what would you give antibiotics? So what are the strong antibiotics you know of in a patient who is suspected of having myocarditis and he had a recent laparotomy? She has a recent laparotomy and she's febrile and you need to give antibiotics. So what antibiotics you would think? Vancomycin, excellent. Vancomycin is associated with the red man syndrome. Gentamicin is also a strong antibiotic. Thank you, RH. Whom else can also, what else in a patient with myocarditis, what is the cause of myocarditis? Is it viral or bacterial? What is usually the etiology of myocarditis? Viral. What type of viral? Let us take an ECFMG question. What is the type of the viruses? It is called echoviruses or adenoviruses. Adenoviruses or Coxsackie A and B. One of them will cause acute pancreatitis, the other one will cause myocarditis. And don't forget the COVID-19 virus and vaccine. Which vaccine? It is the AstraZeneca vaccine. AstraZeneca vaccine. Within 1 month of the vaccine. Some people believe one of the atrocities that occurred with the COVID is the AstraZeneca vaccine. But anyhow, if you did not get reaction within the first 1 month of the vaccine, you will not, inshallah, have any other serious consequences of the vaccine. So the patient, what do you think would have happened to the patient eventually? So I give you a slide about what medication she received. She received tazocine, which is piperacillin and tazobactam. She received oseltamivir, which is an antiviral for flu. She received vancomycin. She received meropenem, and she received metronidazole. What is why metronidazole was used? Why metronidazole was used? After ZU, you are awesome. 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 Thank you. Okay. So this was, do you know what has happened? So the patient who was very sick, she was on inotropes, and eventually she was extubated, and she delivered 7 months ago, but the baby was born with a cleft lip. What is cleft lip? Do you know what is cleft lip? So cleft lip was a congenital anomaly, and it might make the child difficult to suck his milk or so. So it has to be repaired. It could have been associated with the steroid use or immunoglobulin use. I give you more details about the patient. She came to me, the patient, after 4 years. You know, after 4 years, the patient I saw in the ER. But she was not a patient. She was actually a co-patient. And she recognized me because her experience was unforgettable. She told me, I am so and so, and she brought her mother-in-law to get a pacemaker. What did you think I would have done when I saw her after 4 years? This patient who recovered from a fulminant form of myopericarditis, and she was intubated for 2 weeks, and she had laparotomy. What is the simple way of making sure that her heart was back to normal? What would you think I would have done for her when I saw her in the ER after 4 years? Just give me a guess. Are you following me? ECG-L, thank you, awesome. ECG echo, I take that correctly. So I did an ECG. That was the simple way of doing that in the ER. You remember it was 6 o'clock in the morning because she came with her mother-in-law. You see the ECG now? Is the ECG abnormal? The ECG is completely normal and the voltage is normal. So the patient recovered really well from her fulminant myopericarditis. Now we take an example of a chest pain scenario. This is the ECG. If you can see, tell me what are you seeing? STEMI, RS, you are correct. So other than STEMI, what leads are involved with the ST elevation. And what is else also is seen, what type of rhythm. Usually in a patient with MI, you need to see what is the rhythm the patient is having. Is he having a normal sinus rhythm? Is he having heart block? Is it atrial fibrillation? So what is the rhythm and what leads are involved with the ST segment elevation? So V1. Why, if V1 is involved, and what artery? Okay, ZU mentioned irregular rhythm. She is quite right, but it is regularly irregular rhythm, and that is called sinus arrhythmia, which is physiological. When we breathe, so V1 to V4 is anteroseptal. So the occlusion is which artery? And that particular artery, is it proximal? Is it ostial? Is it distal? Or is it a main? It could be a left main, correct? What else? What is the artery involved? It is the LAD. And the occlusion is very likely before S1, before septal branch. Before the first septal branch. So I give you this coronary angiogram, and I get this highlighter. And this is the LAD is occluded here. And this is the diagonal. I would say this is the diagonal. And this is the LCX. But the LAD, which is supposed to come this way, is occluded from its proximity. So the LAD is totally occluded from its proximal part. So this is the patient has a proximal LAD occlusion. Okay. If you allow me, I will go to just one last example. Two last examples. Okay. Okay. So I am going to finish soon, but I am going to show you two examples. Because there is ST elevation in V1. If there is ST elevation in V1, it means that the occlusion of LAD is very proximal. It is almost like an ostial LAD. So I take you to two examples of stress cardiomyopathy, which is متلازمة القلب المكسور. So we take this example. 66 years old gentleman in the ER with severe epigastric pain. Suspected case of acute abdomen. That was his ECG. Any comment on his ECG? 66 years old gentleman with acute abdomen, and that was his ECG. Any comment on the ECG? It is sinus tachycardia. It is obviously sinus tachycardia. There is no ST elevation. Voltage criteria is suggestive of left ventricular hypertrophy, and there is a lot of baseline artifacts, but there is no clear ST elevation. That was on the 26th of August 2022. Let us see the X-ray, the ECG, which was done on the next day after his acute abdomen. Why the ECG? What are the ECG abnormalities now? You can see on his ECG after he was labeled as acute abdomen. There is a STEMI. So what are the leads involved? V2 is involved, V3, V4, V5, V6, lead 2, and lead 3, and AVF. So they are generalized ST elevation, and there is ST depression in AVR and V1. So this is like a STEMI. But the patient came with acute abdomen. So let us see you his X-ray. So the patient has acute abdomen, and he has a very characteristic finding. He has what is called pneumoperitoneum. There is gas. The red marking is due to gas below the diaphragm, which indicate pneumoperitoneum. Usually we should not have gas below the diaphragm unless there is something which has perforated. The gas is only found within the bowel loops and within the stomach. So the red indicates that this patient has perforated viscous. And this particular X-ray finding is called the Liebing-Dolphin sign, or the diaphragm muscle slip sign. It is very indicative of gas under the diaphragm due to perforated viscous. The patient had a perforated bowel. It was the duodenum. And that was his ECG has recovered after 1 month. So his ST elevation was transient. It was due to the stress cardiomyopathy of the acute abdomen. Okay, so it is a stress cardiomyopathy. Okay, did you follow me in this example? So a patient comes with acute abdomen, his bowel is perforated, you do an ECG and you find ST elevation. It is not a true MI, but it is an MI secondary to his stress condition. And you need to treat him accordingly, but you cannot take him to the cath lab if he has acute abdomen and he went and he had a laparotomy. But you need to monitor him. Stress cardiomyopathy is found in 2% of acute or of all acute coronary syndrome. Somebody mentioned cool case. I will now give you the coolest case ever in history of medicine. And let us move on to the next cool case. So,
Doctor, the previous case, what make me suspicious that it's not myocardial infarction?
It could be a real myocardial infarction. You are right, because sometimes you can get a gentleman who has a hernia repair, happened few months back with us. Somebody is the age of 65, he had an inguinal hernia repair. After surgery, he had an MI. So this particular patient, when you do an echo, you will find that there is what is called an apical ballooning. I didn't bring some echo loops, but maybe we can talk about how to differentiate between stress cardiomyopathy and a true MI. It is an MI, and you cannot be 100% sure until you take the patient to the angio. You are right. You are absolutely right to consider this as an MI, no doubt. And if such case happens again, you consider MI as your number 1 diagnosis. Any ST elevation, consider true MI as number one diagnosis. And the only differentiation between will be a coronary angiogram, which will make sure that the coronaries are not occluded. Okay? But sometimes it is difficult to do a coronary angiogram if somebody had a major laparotomy, because this patient can easily bleed and you cannot take him to the cath lab. Okay? Who asked? Satisfied, my friend? Okay. So we move on to the coolest ever. So this is a true case, and it has now been published, and it could be the first case of its kind. So a 57 years old lady had a septic shock and a perforated colon. They called us to see her because her ECG is showing changes. She was in the OR, and that was her ECG before the OR. And they show us her ECG after the OR. So what is happening to the ECG? What is that called? This is a very, very serious ECG change. What do you think has happened after her laparotomy for a perforated colon due to cancer? What is the ECG abnormality? I'm not sure whether you have come across it, but my medical student who reported the case, VTAC, no, think about it. So there is no, I mean, the Q, it is the R wave. The R wave is very abnormal. So the R wave is having such shape. This is the R wave. The R wave have this shape. So like a shark fin, or حقت السفينة, شراع السفينة. It is called the shark fin. This is called now shark, a large R wave. It is called lambda sign. Maybe not all of cardiology has learned about lambda sign. Or this is shark fin ECG. I will show it to you in the next slide. So this is the shark fin. الصورة أنا جبت لكم هذه الصورة. فهذه الآر ويف وهذا شكل الشراع. ترى في بعض الناس ياكلون هذا الزعنفة، ياكلونها. أنا فتحت تيك توك فيديوز وأشوف ناس يشوون هذه وياكلونها. فهذه called are large أو giant R wave. Giant R wave. Called the lambda sign or the shark fin ECG. It is a serious form of, it can happen in the context of anterior MI, and the mortality is almost fatal. I mean, the patient will be likely in cardiogenic shock. The patient need to be taken to the cath lab and to get revascularization. So if you get such ECG, it is like a severe form of ST elevation, but it is involving mainly the R wave. This is called the shark fin ECG. So this is the patient. So this ECG was done what year? If you, it is highlighted here, 2000. Sorry, what is it recorded? 2008. So how did I know that the patient has recovered well from her stress cardiomyopathy at the time of her colon perforation, a colon cancer, 4 inotropes? So in 2023, a group of medical students approached me and they say they want a case report that will hit the literature. So the patient was being followed up in my clinic 15 years after her stress cardiomyopathy. What is the ECG is now showing? Any Q waves? Because if that incident in 2008 was a true MI, the involved leads will be replaced by Q waves. But it didn't. Everything recovered. I mean, the echo recovered, the apex balloon recovered, she herself recovered, and she was treated for cancer, she was treated for perforated colon. So 15 years after her stress cardiomyopathy, she was still okay. Are you following me? Sorry, are you following me? She didn't get cath because if somebody has a colon cancer and a perforated colon, you cannot convince a cath lab consultant to take her to the cath because during the catheterization, they will give a lot of heparin, and heparin can cause an intra-abdominal bleeding. So such cases, sometimes you diagnose it clinically, but it will be deficient. And actually, when we publish it, one of the problems with publication was the fact that we did not cath her or angio her. And after 15 years with a normal ECG, I didn't find any justification to cath her again. But the case was published, and it became one of the first research results. So this was, we published that a shark fin electrocardiogram, a deadly electrocardiogram pattern into Kusubo cardiomyopathy during 15 years of follow-up. Those medical students are graduated this year. I hope all the best in their lifetime. If you open Google and you write stress cardiomyopathy shark fin, our case will come as the first result. That's all I have to say for today. Any question? I come to conclusion. Any questions? Can you get to slide 9? Okay, slide 9. I don't know where is the slide 9. Slide 9. Okay. Slide 9. Okay. وش السؤال؟ تفضل. So slide 9, a low voltage, so sinus tachycardia, low voltage, diffuse, minimal ST elevation. AVR looks random. I don't understand. Let us see the AVR, it is negative, but it is low voltage. Everything in AVR is negative and extremely low voltage. I cannot say something more than that. Batul, are you?
Yeah.
Any question? I mean, you can talk to me now. I mean, you have anything to say, comment, questions?
No, I really appreciate your time.
Okay, all right. Are you all satisfied? Okay, you are welcome. I hoped we could have been discussing it face to face, but anyhow, online sometimes So we hope all the best for you. So best of luck. What year you are? Sorry, what year you are? انتوا كلكم نفس المستوى؟ Clinical years. Okay. What is your ongoing subject now? Ongoing subject? What are you studying these days? Final medicine. Okay. Just before you go, maybe we may not be able. I want to share something. Anyhow. Anyhow, if you have time, not maybe today, but maybe other days, I have a picture quiz in medicine. So if you are, I mean, because I am interested in medicine, pediatric syndromes, everything. So anyhow, if you are interested, we can talk about other cases in the next coming days or weeks. Anyhow, have a nice day and a nice night. Best of luck for all of you. And don't forget to follow me on Twitter and TikTok. Thank you. Have a nice day. Thank you.